Service Center, so lots of very impressive titles at the University of Alabama in Birmingham School of Medicine. All right, so we are going to start with my paper. This is based on a paper that is hopefully coming out any minute now in the Yale Journal of Health Policy, Law, and Ethics. It was due out in January, but I have yet to see it. Oh well. So, I'm going to be talking about physician burnout, which is a phenomenon that is receiving a lot of attention in the literature now. It's quite important and distressing, and it's a good fit for today because it's at least in part tied to electronic health records. So what is physician burnout? So it actually has sort of a clinical definition. It's defined as emotional exhaustion, a sense of diminished personal accomplishment, and depersonalization. That is, a feeling that you are observing yourself from outside of your body. And there's actually an instrument that has been developed to measure burnout. It's called something, oh, there it is, okay. It's called the Maslach Burnout Inventory, the MBI. It has its critics, but it's used pretty consistently as the measuring tool for physician burnout. So why is there a lot of concern about burnout? It's apparently quite prevalent. So there's a very well-known study from 2014 out of the Mayo Clinic, which found that 54% of US doctors report suffering at least one symptom of burnout. And this is very, very high. It's a burnout rate that's nearly double the rate for other professions. Now, burnout is not a problem only for doctors. We also know that it's a problem for other clinicians, nurses, nurse practitioners, and so on. And it's not just in the United States. It's elsewhere in the world as well, but I had to focus on something, so I'm focusing on physicians in the United States. Another number that is frequently cited is 400 physicians commit suicide each year, and that again is double the rate for other professions. Some have questioned whether there is a difference between burnout and depression. Maybe burnout is just sort of a euphemism for depression. I'm going to leave that question alone. For our purposes, it doesn't really matter. Physicians report being quite unhappy. And this is shocking because traditionally being a doctor is the be-all and end-all. Everyone wanted to say, my son the doctor. Everyone wanted to get into medical school. And it's a different world nowadays. So what are the consequences of burnout? Consequences for physician well-being. They are unhappy. Quality of care. There are a lot of studies where doctors themselves report that they are providing a lower quality of care. They feel that they are making mistakes. They feel that they are not treating patients as thoroughly and as well as they would like. There have been some studies that have tried to develop objective evidence of this, and that is less conclusive, but certainly the doctors themselves feel that they are providing a lower quality of care than they would like. And we do have concrete evidence of workforce attrition. So people are retiring earlier than they had planned to. People are going part-time, especially women. They are just finding that they can't balance work and family unless they go part-time. And lots of people leaving clinical practice, remaining doctors, but seeking jobs in administration. So why did I say there's a link to EHRs? Because a lot of studies have shown that. So there's studies that show that for each hour with patients, doctors spend 2 hours on documentation. Documentation takes an enormous amount of time, and we have a new term coined, pajama time. So doctors say they either can't come home until late at night, they have to miss dinner, they come home at 8 or 9 at night, or they come home for dinner and then they spend a couple of hours doing documentation rather than interacting with their families. So therefore, pajama time, and on weekends as well. Another study that has been cited a lot is the 4,000 clicks study. So this is out of an emergency room at a hospital, and they found that even in the emergency room, where you hope there's a lot of hands-on time with patients and a lot of attention paid to patients, but even there, in a 10-hour shift, doctors had to go through 4,000 clicks, so 400 clicks on the EHR per hour. And so doctors describe themselves as no more than unhappy data entry clerks. So another contributor is not only the technology itself, but also regulations. So we've already heard about the meaningful use regulations. A lot of people are criticizing them. I've heard the term meaningless abuse regulations. And now, as somebody already mentioned, they've been partly folded into this new law. I'm going to go through 4,000 clicks apparently just to bring this up. Oh, there it goes. It's partly folded into MACRA, which is a new law that has gone into effect, but MACRA adds its own requirements, and doctors have to learn about compliance with this whole new law, so they are quite distressed. We also heard in a prior session that there are certification requirements, but they are pretty minimal, they are pretty skeletal. So usually certification takes just one day. The vendors get testing scripts in advance, no surprises. I know my students would love that, but no such luck. And so we are not paying enough attention to usability. We're not doing enough in the certification process to make sure that EHR systems are actually helping doctors rather than hindering them, and that usability is optimal. As a result of all of these burdensome requirements, the time that doctors spend with patients does not satisfy either the doctors or the patients. A study said the average primary care visit is 15 to 20 minutes, but I can't remember the last time that a doctor actually spent 15 to 20 whole minutes in the room with me other than in an annual physical. It's often more like 5 minutes. And doctors just feel that that is extremely unsatisfying, that they don't get to know their patients, they don't get to listen to the patients, they don't get to thoroughly examine the patients, they don't get to use their intuition to figure out what is going on with patients. They are more worried about what they're going to do with the computer than what they're going to do with the patient. And some people have said, well, my real patient is the computer. And this is captured, I don't know how clear this is, but I like this drawing. This is a 7 or 8-year-old girl who captured her experience at the doctor's office. So you can see she's on the examination table interacting with her relatives, with her friends, and where is the doctor? The other side of the room, head bent over the computer, not interacting with anyone. So this is a child's view of what it's like to go to the doctor, and I have definitely heard this from a lot of adults. So since we're supposed to be developing solutions, and mostly in the next session, but I'm going to start paving a path, what are some strategies to address burnout concerns? Well, we've already talked about scribes a little bit. These are people that shadow doctors and do a lot of the data entry. Some people are not enthusiastic about that. First of all, you have to pay for them, so that might take away some income. You have to trust them. You have to trust them about confidentiality. You have to trust them about them doing good work and entering good quality data. But I've read a lot of studies, and the people that actually use them seem quite happy, quite satisfied. They feel that their quality of life is better. They feel that they can trust the scribes. There's a couple of studies that show scribes actually reduce errors in the record because they're not multitasking, they're just doing data entry. And other studies have shown that they actually save money because if the doctors aren't doing data entry, they can see more patients. That's of concern because we don't want doctors seeing more and more patients and reducing the time to 10 minutes with each one. But anyway, scribes at least can pay for themselves and are not overwhelmingly expensive. An emerging phenomenon is direct primary care. These are sort of people who go off the grid. So they leave their practice and they will often rent a storefront or whatever, and they will become independent primary care physicians like we used to have. They'll do house calls. They will spend as much time as necessary with patients. They do not take insurance. They do not have an EHR if they don't want to. They take monthly fees from patients, generally pretty modest, $70 or $80 a month. And with that, you're supposed to get 24/7 access and a lot more personal care. And the doctors who are willing to take this financial risk often report being much happier with their careers, with their quality of life. There's also concierge medicine, which is sort of the version of this for the wealthy. They have much higher monthly premiums, and some of them still take insurance to make even more money, but they do take far fewer patients. They are much more accessible, much more responsive to patients, and people that I know that use concierge medicine say, yes, I get same-day appointments. I can call them from overseas. They are always accessible. So I'm considering whether I can find any of this in Cleveland for my husband and myself. All right, why do I think physician burnout is a legal problem? Well, traditionally, the health and welfare of workers is a legal issue. It is subject to regulation, and this is particularly true in safety-critical jobs. And I would argue that doctors are safety-critical workers. We put our lives in their hands. So we have all kinds of regulations limiting the work hours of pilots, air traffic controllers, flight attendants. Some states actually have nurse-to-patient ratio limitations in hospitals. And so it's not inconceivable that we try to enhance the working conditions of doctors in similar ways. And as we've mentioned, part of the problem, I mentioned it, but you're not going to see it apparently. Part of the problem is these very cumbersome regulations. And so that's a legal issue as well. So more recommendations. We should streamline EHR-related regulations, and I am not the only one that has suggested this. Many others have as well. And so it might be useful to simply emphasize just things that promote better patient care. So we could emphasize in regulations trying to enhance interoperability, which we heard a lot about. That is enabling EHRs to all communicate with each other, to work together so that patient records are not fragmented. And so someone who goes for a second opinion at a different hospital or different network would not have to bring paper copies, but those people could, with proper authorization, access all of the patient's records. And then there's a lot of quality measures that doctors have to report, which takes a lot of time, and perhaps we should require only outcome-oriented quality measures and not sort of random data gathering quality measures. And as I've already suggested, I absolutely think that we should expand usability testing for EHR certification. And so maybe not use MACs, but use real doctors in real clinical settings over a period of time so that we can see what kind of problems arise, what issues are working well and what isn't working well with an EHR system before we approve them and deploy them in the market, because the best time to fix problems is before everybody has adopted them and imported records into them. And then a lot of things become irreversible. So much more scrutiny before they are deployed in the marketplace. The other thing that's missing is any kind of continuing review. There is no federal agency that looks at these EHR systems once they are being used, and there's no adverse event reporting. So no government agency collects reports of what is going wrong with these records. We don't have, with these EHR systems, we don't have a record of problems. We don't have intervention by the government to correct problems. And future buyers don't have a way to look at organized information that tells them whether this particular product is good or not good. One thing that we don't measure, I'm really having a problem with this. Okay, technology gone wrong. All right, one thing that we don't measure is physician wellness, and that might be something good to do. So we could have physicians take the MBI or some other instrument and try to figure out if they are happy or unhappy, and if there's what we need to do to enhance their happiness. And if we need incentives, we could include this in CMS pay adjustments so that practices that are doing well in terms of physician wellness get a positive adjustment, and those that are not doing well get a bit of a negative adjustment. And we could try to support and promote remedial measures, such as scribes and direct primary care. So again, we could use incentives to try to get people to hire scribes if we, in fact, conclude that they are helpful, which I think they are. So there's Medicare bonus points for all sorts of things. And a solution that was already advanced but hasn't passed yet is to allow patients to use health savings account for those monthly premiums for direct primary care. So right now that is illegal under IRS regulations, but that could be changed, and there's some efforts, in fact, to do that. I contemplated suggesting some patient visit length mandates, that they can't see more than X number per day or per week. I decided against that ultimately after talking to physicians, because some physicians are more efficient than others. Some have different patient populations. If you have a patient population that's complex, you need more time. Less complex, you need less time. If we have an outbreak of some sort, we actually want to make care accessible even for shorter visits. So this might be problematic, but interesting to think about. And so, 2:20, right on time. I'm going to end here. And James, please.
Goodness, I'm not even on time for breakfast. I don't know how you did that. Goodness, okay. So it's a pleasure to speak with you all today. I do feel a little bit like a fish out of water here, because I have a confession to make, and please don't hate me, but I like the electronic health record. I mean, I kind of do. It's not perfect, and it's got some serious problems, but let me tell you sort of how we see the world in my little corner in Birmingham, Alabama, where I get to practice. So I guess this is accurate, right? So I work in an odd place, and I guess in a good way. And let me tell you, so this man is Mike Sag, and in the 80s, he sort of had a vision for starting an HIV clinic. And he wrote a beautiful book about it. I recommend you guys read it. But I don't think that book tells the story from the point of view of the data. And this is the story from the point of view of the data. So we're talking about a clinic in Birmingham, Alabama with 50 people. And who are our patients? Our patients are people who fled Alabama because there was no acceptance of their lifestyle. They lived in larger cities. And when HIV and the AIDS epidemic sort of strikes in the 80s, and they get diagnosed and they come back home so that they can sort of say goodbye to their people and their lives, and they end up in our hospital. And it's 1985, 1986. Nobody really knows what to do about HIV or AIDS or how to treat it. There's a lot of fear. And this man starts this clinic where he really sort of embodies his principles of having compassion and talking to people and reaching out to the community and educating. So our clinic is founded on all these pillars beyond just providing clinical care. Another thing that our founder did was he decided that he wanted to capture discrete data. So he started, these are the things that are shaded in is what he started capturing. He started capturing demographic data, when you were born, gender, some simple things, therapeutic data, which is basically a litany of everything that failed in the 80s. Nothing would work for many years. Clinical AIDS events. The CDC had defined things as being HIV, and sort of when you went on to AIDS, there was these clearly defined medical conditions that you would qualify as having AIDS. And then there was starting to be the beginning of having some laboratory tests around HIV to help follow. He did something interesting, though. He got a number for every patient that he generated, and he tied it to the samples in the refrigerator that he was freezing from all these people for the basic scientists. And that means that as he presented in conferences, people from all over the country said, so you're telling me that if I ask you a question that's clinical, that do you have this disease, this gender, this age range, you can tell me how many samples you have right away. Sure. So we started getting these calls. And all of a sudden, we were saying, okay, well, we're shipping out 17 samples to San Francisco. We're shipping out 17 samples to Rochester. And all of a sudden, this little clinic in Alabama becomes involved in all of this pathogenesis research that we really had no business being a part of. We get our own crop of basic scientists, and we really start powering up and doing all of this research around HIV. Now, in 1996, at this point, we have therapy that works from 1995 on. And it's great, right? 10 years of HIV research can be summarized as, we tried one drug, it failed. We tried 2 drugs, it failed. We tried 3 drugs, it worked. So we tried 4, and it just produced a bunch of side effects and no better outcomes. So everybody looked around and said, I said to stop at 3. I don't know what you said, but I said stop at 3. And everybody acted like they wanted 3, and we've had 3 pretty much ever since. But now we had treatment that worked, and people were living, and they needed other therapies. What were the concurrent treatments? What were their comorbidities? Were there, there was a lot of metabolic cost to a lot of the early drugs. People were living now, so they needed other laboratory tests. And of course, we found out that different from other chronic illnesses, our chronic illness involved a virus that could become resistant to your therapy. So we needed to know if you were taking it or you weren't taking it. Of course, this means, by capturing all these data electronically, that we became a hub for clinical research on all of these new HIV drugs. And all of a sudden, something like out of the first 15 compounds that were given to human beings to treat HIV, about half of them were given for the first time in this little building in Birmingham, Alabama, which is not what one would expect if you've ever been to Birmingham, Alabama. In 1999, we started getting health services utilization data. Basically, the hospital made everybody schedule their visits. And that was, a big system that they bought, and it was boring. But for us, this meant that adherence wasn't just adherence to medications. That adherence was adherence to, do you show up to your appointments? And we started doing all this research about, if you think of adherence as people engaging with the healthcare system and actually coming, and you start really thinking about, what is our business? Our business is we celebrate birthdays. That's our business. So we had people, and on your birthday, you'd get a call from your clinic. Hey, just wanted to say happy birthday. Because we buried a lot of people in the 80s and 90s. But all of a sudden, they were living. So we'd call them up, and they'd say, oh my God, what happened? Is there something wrong with my labs? No, man, we're just saying happy birthday. What? Who are you? We're your healthcare facility. I promise you, we really care for you. So we started doing that. And with this data, then, we can look at people's adherence to care, how often they come, when do they miss. We start doing all of this research about if you miss visits, it equals higher death. If you miss visits, it equals worsened clinical outcomes in all these areas. And we start really thinking about the continuum of care, from diagnosis to getting you into care, to getting you to maintain your care over time, and figuring out things like, what's the attrition? When are we losing people? And then looking at our clinic sort of as a system, and what do we need to change to sort of do that? In 2004, we took a bold step, which is we refused to use the dictation system for the medical record that the hospital had built, and we said we will not be dictating because we like discrete data. And the hospital said, that's great, so we're going to shut you down. And we said, no, wait, maybe we can find a compromise. And the compromise was, well, if you guys can build your own electronic health record and produce the data and put it into our system, we'll let you stay open. Clearly, they did not know Mike Sag well enough. Mike Sag I always say that if you ever know Mike Sag, he'll hold your hand and you just jump off this building. And then on the way down, he'll say, did you bring the parachute? And he did it. And he jumped off and he got all this money and he built his electronic health record. So we went from this, which is, this is the age of paper records that we all remember fondly. This is a note from that age of paper records. Go on. Tell me that I'm breaking HIPAA. You can't read it, neither can we. And I've also stripped it of identifiers. The guy who wrote this is still our clinic director. He doesn't know what it says. We have no idea. Apparently this person is doing very well. They're still alive, I can tell you. But we made our own EHR, and we built it, and we used it, and it started looking like this. But all of a sudden, if you look at all of those years, how did we look at data? We look at data on this, on a simple Cartesian plane. On the x-axis, you have the data types that your health system is collecting. And on the y-axis, you have the methodological expertise that you have available to you to squeeze information and patterns out of those data. So as an example, if someone were to come to me at my place of work and say, but I'm interested in seeing what are the factors associated with people who we discharge from the hospital and they come back within 30 days after having a congestive heart failure exacerbation. My mind would think of something like this. And I would say, okay, who's your analyst, who's your statisticians? Okay, so you can use descriptive statistics, you can do proportional hazard models, logistic regression, you can do odds ratios, or these are demographic, laboratory, medication, diagnostic, admissions data. Okay, so what you're really saying is you want to go ahead and you want to take demographic, lab, medication, diagnostic data, and comorbidity so I can see how sick everyone was. You want to use a simple logistic regression so you can see readmission, yes, no. And then I want to look at the hospital admissions data to see if you came back in or not. And I look up and I say, yes, we can do that. And sometimes people ask me crazy questions. People ask me, I want to find out what's associated with happiness in patients. And I think and I say, we have no discrete field for happiness. I say, I cannot do that for you, behavioral scientists, but how about we look for some surrogates of happiness together that maybe do plot out in our innovation space. But when you're rolling around and you look at your data as a resource, and you think of the relational table underpinning, this was a corner of our electronic health record, I don't see all those complex tables with all those interconnections. I just see a pile of Lego blocks. Each one of those tables is a Lego block. And it is the combined insights of your operations and financial and research and your clinicians that can take those pieces of data and recombine them to answer questions. But that is everything that you can do if you have electronic data. So I'm here to tell you that is a lot that is bad, but it is not all bad. So we think of data as having multiple lives. There's the clinical lives, which you've heard a lot about today. And let me tell you, I am no fan of documenting an electronic health record. I was not a fan of documenting the electronic health record that I designed for that HIV clinic. And I really liked that one. But you basically have, this discrete fields where you type up what you're going to type, and then you have these, you have these free text fields where you type things up, and then you have these discrete fields that sort of require you to sort of drop down menus and all of that. The reality is that now we share a record, whereas before my note was in my handwriting and I could read it, perhaps you could not. Now my documentation is your problem directly because we share the same record, and that record maybe has some underlying things like decision support and all these safety things that can trigger. But if I don't do a good job documenting those things and you go prescribe medicines, there's nothing for you. I have sat in the room and had a family passionately tell me, gosh, look at Grandpa, he's in terrible pain. You got to do something about it. And I say, okay, I'll do it. And I said, let's give him a dose of this. And I look at the allergies and there's nothing there. And I look at the medications, there's nothing there. And I've been down the hall after seeing 2 more patients and I see a cold blue called and everybody rushing in because Grandpa is dying from an opiate overdose. Because nobody had ever documented, family hadn't told me, and the patient hadn't told me that he had an opioid pump already in and he was in renal failure. So he already had drug levels that were incredibly high. And here I gave him sort of the coup de grace. I don't know how much I should be saying in this room. But we revived him promptly, and he's doing great to this day. Shared records, shared responsibilities. But we never talk about data quality. They will drag us into these rooms and really train us on the EHR. And boy, you haven't lived until you've had that day in your life. They sit you down, and they say, let's go through this great 10-page thing, and there's about 500 clicks. And for 8 grueling hours, 6 if you're lucky, they will show you how to do every minuscule task that you will never do again in an EHR. Because what you really need to know is the critical path that's associated with your practice. But no, let me show you the 20,000 features I can do. And in frustration, you say, can the EHR do this? And they say, of course. And they go, 18 clicks in rapid succession. They say, you see? No, I don't see. And I'll never remember that. I don't remember my password to log into my email account. So we never talk about data quality. And the thing that was very unsettling about our colleagues was that once we had an electronic health record, everybody assumed because it's electronic data, it's great data. We're good now. So we hired a bunch of grad students in the School of Epidemiology, and we sat them down and we said, simple exercise, read the assessment and plan section of every note we write. And every diagnosis we say is resolved, or every new diagnosis we add, pardon me, every medication we start or every medication we stop, make sure that we did it on the discrete fields. And how much do those things match up? 53% of the diagnoses that we were mentioning in the free text were we actually putting in discrete fields. And we started an intervention, and we did it for a while, and we brought it all the way up to 78%, which is still not a lot to brag about. For medications, it was 88%, and that's basically because you can prescribe a prescription, and sometimes if you get good at that, you can do it electronically faster than you can write it on paper. However, that's, we got that up to 93%, but think about it. That's more than 1 in every 10 prescriptions that we write is not available to the electronic health record. So tell me about your medication, your drug-drug interactions, and your allergy to drug prescription interaction. All of that is useless because you have not taken the care to give me a system that I can document easily in. And the reality is that every clinician is looking at their watch and they're thinking, geez, I got to get to daycare to pick up my kids. I'm going to get fined $60. But I'm not even scared of that. I'm scared of my wife. When I get home and the kid hasn't eaten and the kid is like going crazy because it's an hour after dinner, I got to get out of here. So you document, and everybody you work with in healthcare is smart, is at least as smart or smarter than you, and they can all find a workaround. And they all do, because they all got to survive, and they all got to get home. And they do every day. We did some analysis on our data because we felt our attending physicians said, yes, these are our experienced physicians. They say, I can see how the new physicians, the fellows and the nurse practitioners would be making a lot of documentation errors, of course. And of course, if you were an attending physician, you were 4 times as likely to make a documentation error of omission than anybody else. And if you were a fellow, you were twice as likely. So my advice to you is get a good nurse practitioner into your life because they actually document. The rest of us, not so much. We also found that your first 6 months in practice, this is when we really start seeing your documentation errors. Because we started looking at people longitudinally, we started finding patterns in their errors of documentation. And they would receive a call. And we would say things like, but the first visit of everyone to the HIV clinic is the day that they contracted HIV. Do you have a vial with HIV that you inject into everybody's veins when they come to see you? No, how dare you? No, I'm just asking because that's what your data seems to say. So perhaps you want to date it appropriately so that when we're asked about the severity of this comorbid condition, we can say, yes, they've had HIV for 10 years and these are all the meds they've had before. But if you don't look and detect for the patterns in the error documentation of your providers, you first don't learn how you better change your EMR to make it easier for them to document. Don't default today's date to every diagnosis you add, for example. And certainly, you can't give them any feedback. And when you train people, talk to them about data quality, about how they use your EMR. But the words data quality have never been mentioned into any training I've been for an EMR, and I've been to about 4 or 5 different training sessions for different EMR systems. So you've got to establish and maintain a culture of data quality in your institution. You've got to do something about this. You need to have systems to gauge the data quality, and electronic documentation does not equal quality documentation. It is, as a statistician that I've worked with closely loves to say, every data set is perfect until you analyze it. That's the clinical life of data, and it's a lot of what you've been hearing today. But there is an enterprise life of data too, where data are used to meet operational goals. They can be financial, quality and safety, patient-client satisfaction, efficiency, compliance, clinical effectiveness, all kinds of things. And usually there's a clinical warehouse somewhere in the health system. And we have one called Power Insight we bought from Cerner. You can put things in data formats like I2B2, and you can share data across the country, but it's a lot of sort of shallow data but it's a lot of data that you can share. And here's an example of something we did in our organization that we couldn't have done without this record. This is a heat map of how many patients are seen in the ER, because we were having a lot of long ER wait times. And we had every shift staffed fully and all of that. If you worked in this ER shift, boy, you had a difficult life. There's a lot of orange and yellow in your life. These people, they look very disheveled. The burnout was high. The Maslach was not good. If you worked in this shift, you knew the full plot of every episode in Game of Thrones. You were on top of everything. I could ask you about any pop culture thing, and you would have said, yes, I watched that last night at work. That was a wonderful episode. So we basically realized we got to take 2 people out of this shift and stick them in this shift and sort of level things out. But these are the types of things we would have never been able to do with data. We would have heard all of these complainings, and we would have sort of gone around. So our EHR pitch to our providers is not an EHR pitch. This is our pitch to them. It's honest. We say, yes, this is going to be an impediment, and here's how it's going to impact you. We also make sure that we train them on data quality, that we monitor them, that we give them feedback on sort of what are the common errors in documentation you are making. We talk to them about the benefits. Yes, your life will suffer somewhat, but here's what's going to be better. We're going to be able to look at the quality. We're going to be able to have quality metrics in our clinic about everything that's good. I'm going to be able to tell you, because you're about great care. You're about making sure people do well. I will be able to tell you that 2% of your people aren't vaccinated for that they should be for this, or you haven't ordered a mammogram or a colon screening on these people, and here's the list, and here, I'll help you do it. And when you really talk to your providers like that, and you say, here's how we're going to do a better job together, the conversation is a little bit different. And when you're honest and you say, yeah, this sucks. Sucks for us too. I'm one of you. But here's how we're going to benefit our patients. Here's how we're going to do better. And we think that developers and clinicians need to spend time together. The real design principle here is you have to make the right thing to do the easiest thing to do. The scribe conversation amuses me. We had scribes before. You know who was a scribe? Me. When I was working on paper. I wasn't a great scribe then either. Maybe this scribe is great, but you know what would also be great? That we actually took the time and embedded the technology people with the clinicians at the point of care so that they could see, wow, I really understand why your life sucks and why this workflow is so crazy. And you have goals, like this healthcare organization in Wisconsin that I saw at one conference, and they said, our program and team lives with our clinician teams, and they round together, and the goal is to reduce data entry by 1 click every week. Now you're talking. If you were doing that, we'd probably have a different opinion about EHRs. And the thing to everybody is, everybody here is a data scientist. You know, my operations people are sure that what they do is unique and nobody understands them. The same with my researchers, the same with my clinicians. They're all the same. They come up with questions, they review previous findings, they come to me to get a data set, they get a statistician to model it, then they analyze it, and then they present on findings in conferences like this, like I'm doing now. But it's all the same. The name of the questions and the professional language is different, but it's the same process over and over. All right, I think I'm sort of running short on time, but I wanted to tell you sort of something new that we started a while back, but it's a sort of patient-captured information. The cheapest data entry clerk in your clinic is the patient. You don't have to pay them, and they're just sitting there waiting for you. So give them a tablet, have them do some work. So we gave them a tablet. They start here, they start their questionnaire, they get to the room, they continue it. I can watch their fill percentage of how much they've done in the clinic. This person, I can see how much time they spent. If they spent over 20 minutes, I go knock on the door. This is how I now know that 15% of my patients cannot read and write. These are people that I prescribe 10 simultaneous medications to all the time. And I'm incredibly frustrated because they're not taking them and they're not getting any better. I didn't know they couldn't read and write. I couldn't keep up with 10 medications myself. And I think I know how to read and write. How are they going to be able to do it? So if you fill this out, now I have, there's depression, suicidality, adherence to medications, all kinds of things. We also layer response systems on this. For example, if you're suicidal in our clinic, a page goes out automatically from the system to the social worker and the psychologist, and they both converge, and we have an established plan for safety, and we go through it, and we put that patient either in the ER, or they're meeting a psychologist right there, or a psychiatrist tomorrow. If it's intimate partner violence, we can get you to a shelter with a cop sitting beside the abusing partner smiling in the waiting room. These are all things enabled by technology. So these are just some papers we've published on these things, and I won't sort of delve into them. But in essence, it's not all bad. We just need to be a little bit more mindful of what I like to call the rules of data. First rule, you got to, as an organization, separate the data you want from the data you need. And if you ain't using it 5 times, don't bug me to collect it. If you're not going to reuse it 5 or 6 times, get on out of here. We don't have any types of controls around data. There should be, in my opinion, an office of data quality in every place. And if you say, but I just want to add one data element, you and the rest of the world. Let's talk about why this is important, why this is mission critical, and if it isn't, thank you very much. Go do a research study somewhere and pay people to do this extra data entry for you. But if it is important, it's critical to the survival of the organization, then you have to do the second rule of data, which is depending on how important the data is to you, that determines the mode of its documentation. That's when I lock in people into screens that they can't leave until they add that there. And the third rule of data is just a realization of what the world is, which a provider's capacity for chaos in their documentation will always slightly outstrip your capability to correct it. You are running along in a never-ending carousel, and data will always have errors in it. Thank you.
Okay, so I think we'll sit up there and Max will be in charge. But 2 quick announcements. First of all, if anybody is staying overnight, any of the speakers, Ross Tell wants to have dinner with you. Or talk about social activities. That's Ross right there. And second, if you're interested in reading more about many of the topics we've discussed, I actually have a book on it, Electronic Health Records and Medical Big Data. I think there's a flyer in your blue folder. So feel free to buy it. Oh, the cost? On Amazon, there are all kinds of costs. So, depends on the hour. But, all right, we'll be happy to take questions. Yeah.
So I'm thinking about physician burnout, and I'm thinking about some of the market solutions, because I'm a market-oriented guy, not more regulation kind of guy. And Charles Schulz wrote the classic book that sort of undergirds my question, which is he wrote a book called Public Use of Private Interests, about how much market approaches are much better than a lot of regulatory approaches that keep running amok with regulation. So the 3 ideas I inspired by Dr. Willig, you gave me one, which is what we need to do is generalize your ability to have an EHR system that didn't go through the certification process. I'm thinking, I don't know whether they could possibly issue a interpretation that no certification is required anymore, or we have to repeal the certification. But I think of a market approach to EHR, and any company could enter the field with an EHR and not deal with all these things that we heard about. Be much more responsive to doctors and hospitals. So repealing certification is one market idea I'd throw out. Secondly, Naomi Ray, as you may or may not know, I'm not political, I'm more of a doer, but she was charged with repealing or going after regulations that are unnecessary. So I'm thinking of sending her or whoever her replacement is a list of regulations that are really unwarranted and unneeded. That's her job, and she's apparently done a terrific job so far. And the third idea is, my understanding is Dr. Burnout, one of the contributors is medical malpractice. And so I've talked to Daryl about there is a way to get medical malpractice reform outside of legislation, and this with the Federal Arbitration Act. But again, those are market approaches to physician burnout.
Well, thank you. Actually, in the surveys that they've done, malpractice does not get listed high as a cause of burnout. EHRs consistently get listed high. Inability to spend time with patients, work-life balance, those kind of things are much higher than fear of malpractice. But there are other programs about malpractice where they'll tell you that's a key concern. So,
I think there's some fascinating things coming up with malpractice. I think in the morning we were hearing about machine learning and its potential and role, but there's some very interesting books. There's one called Weapons of Math Destruction, and there's one called AIQ, which I think are two things. There's also one called Algorithms to Live By, but I think those are three books I've read the last couple of years which I think are very interesting, and I love to read sort of books that are against my point of view, just to kind of say, wow, how would I attack myself? And I think you learn tremendously when you do that. And I think in those books it really talks about, yes, you're going to have training data, but if there's biases in how the data that you're using to train were collected, what you've basically done is you found an electronic tool that can take prejudice and really do it efficiently in a system-wide level. So it was a terrifying sentence to read, but I think there is truth to that. And I wonder, the question we've been pondering this week, some colleagues of mine, is, the AI algorithm gives you a recommendation and you do something, whose fault is it? Is it the doctor's fault for prescribing that? Or the doctor can point at the algorithm? The developer of the algorithm can point at the training data. The training data can point, well, it was captured by all these people. So I don't know. We've not reached any consensus, but I wonder, you sharp legal minds, how the heck are you going to navigate that?
Yeah, I think, Max, we've discussed that, and it's not that different from a test or a device making a mistake, right? Is that what you told me? If an algorithm makes an error.
Yeah, until the time that we sue the algorithm.
So, Dr. Willig, thank you for being an island in the midst of chaos. I won't use the other metaphor. So, have you had occasion to look at turnover in your staff, kind of as a reflection to our theme? I love your enthusiasm, and so I'd like to presume that many of your colleagues and staff are equally, engaged in your mission and purpose, and thus burnout drops.
I'll be honest with you. They've actually started doing the MOSLOC and some other indexes just sort of throughout the health system for all physicians, and I'll tell you that my burnout index is terrible. They basically when I fill it out, they say, hey, here's a number to the suicide hotline, which is that really scared me. I was like, whoa, wait a second. So I think that it's very complex, and I do think that my personal opinion is that the EHR is sort of the place where we point to a lot of things, because the EHR is what we see as keeping us from patients. But I don't think the EHR is the etiology. It's not the cause. I think it's a symptom of other things. And I think somebody earlier today made some interesting comments. And I think burnout has to do as well with, the thing that's resonated the most with me is recently I saw that if I would have been practicing in the 70s, I would have seen 3 to 4 patients in the morning, and I could have been in the afternoon to see another 3 or 4 patients. Multiply that times 3 or 4, and that's my morning today. So I think it's more than just the EHR, but I think the EHR is, recently I was talking with one of our colleagues yesterday. They're interviewing people to be the head of family medicine at the University of Alabama of Calusa now. Great place if you know a good candidate. And these folks, every one of them was asked a question about burnout and faculty, work-life balance. And all of them laid into EHRs, all 5 of them. They said, well, the EHR is destroying family medicine and all of that. And I was aghast. I was like, man, I don't think they're that bad. I think they're a part of it. But it really is. Generalized, people hate EHRs, and everything is pointed at them. And frankly, I think it's more of a symptom of, not the cause of a lot of this.
So Anne has a question up there, please.
So part of me feels like we should just end after your enthusiastic disclaimer of hate for EHRs, because I had been feeling so depleted about the state of our healthcare system. So thank you for your presentation. My question, though, I have worked in 2 enormous healthcare institutions in the clinical bioethics arena, so encountering the consequences from both directions of overstressed physicians and dissatisfied patients. And in both institutions, I would hear the comment that the huge, rapid growth of these institutions contributed to the fragmentation, not just of care, but of the level of aggravation derived from the EHR that didn't. And so it just struck me listening to you. You said your clinic has 50 employees.
Oh, no. We had 50 patients in the 80s.
You had 50 patients in the 80s.
3,700 now.
700 patients.
3,700.
3,700. And how many employees?
Goodness. The challenge with giving you an answer there, I think clinically we're probably more around 30, but the clinic has more personnel in that because there's a research arm and there's sort of community outreach arm and education arm. But clinical work, probably around 30 people.
So both the homogeneity of the disease of patients you treat, and my big question, I guess, is what's the relatability of your kind of internal healthcare system to scale to the level of a Cleveland Clinic or an MD Anderson with innumerable specialties? And, it relates to the comment, too, about market solutions.
So I think one thing about HIV is, all of us that went into infectious disease sort of in the 90s, early 2000s, we were very excited because we were going to treat a lot of exotic infections. And then the therapy was so good that 85% of our people are living regular lifespans. So then we went back to being internal medicine doctors. So I spent most of my time treating diabetes, hypertension, and high blood pressure, which I really tried hard to get away from with some additional years of training, but I'm back to where I began. I chose to sunset our EHR and favored adoption of a Cerner commercial health record in 2011 in our system. We maintain our patient-reported outcomes capture in those systems and are still working hard to try to feed them into Cerner. And our approach, I think, is quite scalable because infectious disease in HIV, it's family medicine. So I've spent a lot of time talking with specialists from all clinics at UAB. And I think a lot of the recommendations I make really are sort of from the organizational perspective, where I think we had a controlled ecosystem where we could have some regulation around data capture and we could have some control about the data capture formats. And I think that's what's needed at a health system level. But you really need to have those conversations where you say, one of the most terrible things is twice removed, a cousin of someone in risk management says, I'm only saying risk management because of my colleague in front of you. Someone says, hey, you've got to capture this. You've got to capture this data element now because it's critical. But there's 50 places in the institution, and that all gets added to a template, and it's madness. Whereas if everybody could sit in the room and say, let's have an office. I've always dreamed of I have a name for it, the Office of Data Integrity. And we just talk and say, okay, what piece of data do we all have to capture together? And what's important? And if it doesn't show up that we're going to reuse it 5 or 10 times, no, we're not going to do it. That's the kind of stuff that drives you crazy. Yes, but. Data capture goes crazy.
Max, there's a question here, please.
It's more of an observation. I think a lot of times people try to tell the doctor, you can get the doctor to do it what's in it for me? And I usually tell them what's in it for the patient. I think one of the reasons why you had such success is because your doctors could directly see the utility of collecting the data and how it would benefit their patients. So they were willing to do it. I think that one of the problems we have with doctors in general taking on the electronic medical record is they can't really connect the dots between really being attentive to the electronic medical record and how that's going to actually impact and improve the patient care. And I think that that's one of the really big problems we have, because I spent a lot of time teaching ICD-10 and trying to get people to get granularity and, give me specificity. And it's like, why? Because I can bill the same if I pick diabetes versus I pick type 2 diabetes with neurologic complications.
Yeah.
Okay, Anthony?
Thank you both very much. Professor Hoffman particularly, I'm curious about what you think of intrepid law students or other academics like yourselves who look at the healthcare system, identify a weak place of regulation, add really useful suggestions, and then also have to consider the fact that it might add to physician burnout? How do you deal with that balance?
Yeah, there's no easy answer. Anthony, you should know that by now.
Minus 5 points again.
It's not final. So even in my paper, right, I say, oh, we have to streamline regulations and so on, and then I say, oh, but maybe we should measure physician wellness because that would be really useful. And some of the readers that I had said, oh, no, you can't possibly suggest another quality measure that goes against everything you've said beforehand. So, I mean, there's no easy answer, and you just have to try to reach a balance. But yes, anytime you suggest regulation, you're going to make someone unhappy. Our regulator just left, so I would have asked her. You're going to make someone unhappy, and perhaps, but a key point is just to consider physician burnout, to consider anytime you're making a change, what effect will that actually have on clinicians on the ground? So that would be a good first step. All right, so one more question. No? Well, I'll take a no, you're okay. You're the only one, so.
Well, I think the key there is there a purpose to it? I mean, there are near infinite numbers of studies of what makes people happy. One of the critical components is, does this have purpose? If I'm being told I have to do it because of X, Y, Z, and that has nothing to do with why I'm doing X, Y, Z, there's a disconnect. And so, I mean, the discipline that James described, where you don't develop it unless you have an end user who's actually going to use it more than 5 times in the foreseeable future, and the other is that you design from the beginning. And actually, this also goes to something our friend from the doctor's company said at dinner last night, which is, before you initiate a data gathering exercise, what are you going to do with the data, and what kind of decisions do you plan to make based on it? And once the enterprise understands what it's doing, even if there are people who don't want to do it, you can at least explain. And that, to me, is one of the major parts of what I've seen. I had the pleasure of working for the data quality office for Navy medicine, and they understood what they were gathering and why. And they worked incredibly hard, and burnout was low because it was all about a mission and it was all about a purpose. So I think one of the things that we sometimes forget is that in the midst of all of this, there are certain human characteristics. If I tell you you have to do something, try doing this with a 10-year-old, and I can't explain why, you're going to get resistance. This is natural human behavior.
Yeah.
Sounds good. All right, so we will. All right, one more session. So this is our solutions session where we're going to try to put the whole day together. Unfortunately, Leah Binder could not join us because of a death in the family, so it's all up to Steve Stephenson. He is a neurologist, chief of learning, health system, clinical affairs, the University of Texas at Austin, Dell Medical School, and then we will open it up for comments from the other panelists and take questions. And so we're looking forward to your presentation. How long do you think?
About an hour and a half, 2 hours.
Okay, good.
That's very good. So this is going to be a whirlwind tour through part of my own career, through some ideas I have. To stand up here and to try to pretend that I have all of the solutions in any amount of time, I think would be a ridiculous claim full of an amazing amount of hubris. And so Instead, what I'd like to do is just talk through a little bit of my ideas and kind of what has led me to those ideas through the course of my own career. I've had a lot of varied experiences, which we're going to sort of talk about, but I have no potential or actual conflict of interest, which hopefully will become relevant once you learn about where I came from. And thanks, Reed, for the boost to Navy medicine and your prelude to me coming up here. So, oh, it's not going up there because I'm hitting the wrong one. There we go. So I'm going to tell you a little bit about where I came from. I came from the Department of Defense, and I had a pretty amazing career working for health affairs inside the Department of Defense. So before I was the neurologist at Dell Med School, which I will talk a little bit about what I'm doing there later in the presentation, I had a pretty long career in sort of health IT. I've been programming since I was probably about 10 or 11 years old. I paid my way through college as a first-generation college student by programming at the dawn of the internet. My fourth year of med school, I co-founded an EHR company. We didn't call it an EHR company because they didn't have that phrase at that time, but that was essentially what we were trying to do. And then upon entry into the Navy, I did my internship in internal medicine at Bethesda Navy Hospital and Walter Reed Army Hospital. Joining the Navy at the time where they were going to pay for all of my tuition. Cold War was over. What are the chances that something bad's going to happen? That was July of 2001. And so September 11th, we watched the events unfold from the intern lounge at Bethesda Navy Hospital, knowing that most of us would be deployed somewhere in the world. We didn't know where, but somewhere in the world the following year. And that happened to everybody but me, largely because, including my now wife, got deployed, largely because I was the only neurologist being trained in the Navy my year. And so you can imagine with the kind of injuries that we were seeing coming back with TBI and PTSD in particular, there was a high demand for people like me. We were getting people back from the battlefield in 48 hours back to Walter Reed and Bethesda. So I was a neurocritical care person for most of my training. Going to Pensacola Navy Hospital was sort of my next step. You're not going to be able to read all of this, just sort of looking at the pretty icons, more for a reminder to me. The commanding officer at the time, who was the CEO of the hospital at Pensacola Navy Hospital, later went on to be the Navy Surgeon General, which plays out in my story a bit. But he knew of my IT background. He knew I'd done this thing in my fourth year of med school. He sort of knew I was a programmer. And we had this new electronic health record rolling across the military called ALTA. And while I was at Walter Reed, I had the good misfortune of playing on pretty much every single EHR prototype of ALTA, which was the homegrown EHR that the military had created. And so he asked for me to lead the rollout of this electronic health record. As a result of some of that, which I'll show you some of the details of what happened with that, there was a joke a bit that I would either be court-martialed or promoted because I backward engineered the electronic health record to have a different user interface and really trying to focus in on the usability of what we were seeing. And I have countless examples of what I would try to do to illustrate that to the programmers. That got the attention of the higher-ups inside DoD, and they asked me to stick around. And so following my tour at Pensacola Navy Hospital, they asked if I would like to run the health IT research arm for the military, which is a $500 million a year program at the time at TATRIC. So the Telemedicine and Advanced Technology Research Center, I was the CMIO there. A major research funding arm of the Department of Defense, actually the largest at the time. So I ran health IT efforts, and in that role, this was around the time that interoperability was happening. ONC was sort of pushing down a lot of things, and my team is the one who created the open source adapter that went with the NHIN Connect gateway, and we released that into open source. And a lot of people always used to ask me, why is the DoD so interested in interoperability? It's like, well, we have a worldwide deployed electronic health record, and we have the largest, most mobile patient population. Every 3 years, our families move on average. So how do you maintain continuity of care, especially when 60 to 70% of our patient population are seen on the outside? They're not even seen in our electronic health record. And so how do you maintain continuity of care without interoperability? So we became huge champions of that and trying to really open up the work that we were doing. Of course, then it was taken on by unnamed vendors who shall remain unnamed and bastardized completely, but at any rate. Subsequent to that, I went and did some things at Hopkins for a little while, came back. The Army Surgeon General, who was new in her job, found out that I was getting ready to go work for the VA, and they were needing a lot of help at that point under Terry Cullen, for those of you who know Terry. And she asked me to come work with her, and the Surgeon General found out and said, what do I need to do to come work for me? And lead Army innovation, this concept of health innovation inside Army medicine. It was an interesting situation. She was the very first female Surgeon General that the military's ever had and the first nurse. So she had a very different perspective on health and healthcare, and she wanted me to help her sort of roll that out from sort of a technology perspective, which I did. And when she retired, the Secretary of Defense for Health Affairs asked me to come do that for the entire military health system. So I did that just prior to coming to Dell Med School. So that's sort of some background that's relevant. I used to show this next slide. And that was me as my uniform there. I give this slide because I was sort of the historian for many years inside the military health system between what was happening between DoD and VA health systems. And I started building out this sort of chart of when did certain systems come to be between DoD and VA. I had the very good fortune and honor of knowing many of the original VA programmers, Tom Munneke, you can sort of go down the laundry list of some of these people, Jim Garvey at Indian Health Service, who were very instrumental as physician innovators for developing some of the earliest EHRs in the 70s and 80s, and then rolling those out across large systems. You can sort of see as the internet sort of gave birth, as the world sort of saw the internet and the explosion of different programs and initiatives, particularly on the DoD side, leading all the way up to sort of 2017. All of this in the context, by the way, of a couple of wars that were going on at the time. And so there was also this huge demand of being able to see what was done to a patient at launch tool 24 hours ago before they arrived at Andrews Air Force Base, for example, where I would see them. So a lot of sort of this IT landscape that I sort of wanted to point out a little bit. So before I dive into like solutions in health IT, I think it's probably appropriate to frame the conversation maybe a little bit differently, just to give us something at the end of this that we can maybe have in our tool belt to have an intelligent conversation rather than either love it or hate it conversation about EHRs. So I wanted to talk a little bit about an innovator in health IT that I've come to know. This was a young whippersnapper, 28 years old, who at the time was leveraging a piece of technology that wasn't originally intended for healthcare, but his use of that technology fundamentally changed healthcare for years and years and years, actually. But was seen as really a rabble-rouser, a revolutionary. Was not well respected in the beginning by a lot of his elder peers who were used to the way things had been done for many, many years. And I could have started anywhere, and what I want to do is to flip on everyone's head a little bit this idea of what health information technology actually means. I think that many times we start with sort of a digital approach, but the IT innovation I'm talking about is actually the printing press. So in the 1400s, and the innovator at age 28, Andreas Vesalius, who created one of the best anatomy books that upended a millennia, actually, of common knowledge presented by his predecessor, Galen, on how the human body actually looked inside, what it looked like inside. And at 28, published his famous anatomy book that became the standard for about 300 years. In fact, the first edition of Gray's Anatomy that came out actually had some of his original wood cuttings and etchings, which he hand-carried, by the way, from Venice across the Alps to print in Switzerland back in the 1540s. With that, we have these beautiful wood etchings, which actually today, even from, I'm a neurology instructor too. I'm the course director for our neuroanatomy course at the med school, and I use these images actually in my course. They're beautiful pictures of what the inside of the brain looks like. For my non-medical friends, the image there on the right is the venous sinuses inside the brain. To be able to draw that in the 1500s, etch that on a piece of wood, carry that over and print it, that is an amazingly accurate representation, actually. There's a few errors in here, and that sort of highlights another point, that even though he was upending a lot of previously held information with the use of this new technology, a use of a new way of conveying information that previously had never existed, there were still errors in it. For example, all of the neck anatomy is inaccurate. Why? Because most of the cadavers that he was dissecting were former criminals who had been hung. So the neck anatomy was horribly injured, and so he used dog anatomy instead, thinking it was equivalent. Okay, so just because something does upend over 1,000 years of clinically held dogma, and we begin to venerate that person, there are still errors that exist within that. So what are some other examples of innovation in healthcare IT? Again, getting you to think about this a little bit differently. The camera. When we think about medicine, we generally think of this sort of nostalgic view. So this is Eugene Smith's pictures of the doctor, the country doctor, printed in Time in the 1940s. And we tend to think of that doctor as being the guy who gives all those house calls, but photography actually brought us something else in the world of health IT as a way of thinking differently about how we convey information for changing health and healthcare outcomes. In particular, this is a series of photos done in the 1860s in Glasgow showing the inner city living conditions at the time, fundamentally changing the perspective of what health and population health and public health measures needed to be taken, largely because of the photographs that were being taken as part of this series. I don't know if anyone recognizes the photographer on the right. He's actually a journalist named Jacob Riis. He was a Danish immigrant to New York, wrote a series of articles while he was in New York. The police commissioner actually got very interested in what he was doing. This image that you see up here, I usually pause for these images, but we just got a lot to go through, so I'm going to just tell you what I'm looking at. A lot of people, I say, what do you see in this image? This was a tenement. This was an area where a lot of people were crowded in New York, and most of the inhabitants, the wealthy inhabitants in New York, actually had no idea that there were these sort of crowded living conditions. And I usually say, well, what do you notice? And people sort of say, well, there's like a stove in there. There's like a lot of people. There's a ton of people in this room. And if you try to count them, it's actually difficult because you're not sure if one lump of person is a body or not. But the big thing is all their eyes are closed. And so because they didn't know when the photo was being taken, the flash is what gave it away as the photo being taken. But Jacob Riis was sort of famous for the photos and the essays that he was taking, and he got the interest of the police commissioner at the time, who didn't believe it and said, I want to go with you and actually see for myself what you're actually witnessing. And so he did, and they became lifelong friends, actually. That police commissioner's name was Theodore Roosevelt, who later went on to be president, and on the Bull Moose ticket, actually, ran on a socialized medicine platform, largely because of the work that Jacob Riis had shown through his efforts documenting the living conditions of the poor. He's actually the one who wrote the book, How the Other Half Lives. It's where our phrase comes from, is the work of Jacob Riis. But in medicine, photography was used a little bit differently to convey information. And so this person that I just showed you before, I'm going to be able to go back, but I'll show you here again, is Duchenne de Boulogne. Duchenne was a famous neurologist. It's where Duchenne's muscular dystrophy comes from. He has about 15 different eponyms named after him. But one of the things that he's famous for is being one of the earliest physicians to actually use this newfangled technology called a camera to be able to document in real time that what you couldn't do with a picture or what you couldn't do in text. And it was the muscular contractions of his patients who he was shocking. And so he takes this old man who he has really bad things to say about. He's a boring old man. We don't know very much about this gentleman, actually. We know some accounts call him a cobbler, others call him intransigent. But the comments left are not very flattering by Duchenne, actually. He said that the gentleman didn't have any sensation in his face, and so when we see pictures like this, we shouldn't be too alarmed. But modern accounts, including my own neurologic eye, say, yeah, I don't know of a condition that does that doesn't cause other things that I would see in a picture. But he did a series of photos that actually really significantly informed the state of medical practice. Using this technology alone, was able to capture this information in a way that previously was never able to be done. He also performed this on women, on a few actors, and even on a child you can see in the lower right-hand corner. He published a very popular and famous book at the time, actually talking about and upending centuries of how we believed that emotions worked. For a long time, we thought that emotions were more sort of generated in the soul, but actually, is something that were unique to man. In fact, one of the people that picked it up was Charles Darwin in his book, Expression of the Emotion of Man and Animals, and actually used some of Duchenne's photos in his book. Those photos were actually given to Darwin by his friend Sir Charles Crichton Browne, who ran the West Riding Lunatic Asylum. Crichton Browne is actually a wonderful mustache also. I know a lot of you are sort of noticing the mustache there. It actually has a special name, which I forget now, but people grow them out. It was really fashionable at the time. But what he was using in terms of photography was a way to try to raise awareness about the status of mental health care at the time. UNESCO has identified him in the 5,000 works written and photographic works that he's done as being international cultural treasures. He has a very widely regarded positive reputation, and yet with our modern eye, we sort of look at some of these photos that he began taking of patients that were at the West Riding Lunatic Asylum, to include some that are clearly disturbing, and we start to wonder and question the use of this technology and maybe some of the unintended consequences for the perceptions of mental health, particularly later in life. This was a time, remember, when photography was being used also in mugshots. So you had not only what does an insane person look like, there's what an insane person looks like. And if that looks like your uncle's insane. But also what does a criminal look like? So these unintended consequences of these new technologies had pretty deep meaning culturally and that we could not have predicted. And he certainly hadn't predicted and was seen, like I mentioned, as sort of a pillar of an advocate for mental health care. So again, we sort of see this picture here. This is by Sir Luke Fields called The Doctor. And I will pause for just a minute while I read an account because I think it's interesting. So this is a little hard to see, but what you see, I hope, is that there's a physician looking down on a child spread across two chairs. You see the father in the background, his eyes beaming on the physician here who's trying to take care of them, some medicines or something on the table. Most people don't recognize the mother crying in the background. And the question is, what's in this doctor's head right now? So for the physicians in the room, anyone want to sort of volunteer what you think that doctor might be thinking right now? Where's the EHR? Right. Right. And actually, it's a great question of how did people actually document in that time? And I've got a whole other talk on that, but we'll skip that for now. I look at this as a modern-day physician and think, holy shit, what am I going to do for this patient? I have nothing to give to this patient that is going to ultimately save this little girl. How am I going to have the conversation with them about this patient is ultimately going to die? Right? So the quote here is from The Youngest Science, which, for my medical colleagues in particular, if you haven't read it, it's sort of a classic book by Lewis Thomas. And he reflected on his memories of his second year at Harvard Medical School. And he said, quote, "During the third and fourth years of school, we also began to learn something that worried us all. Although it was not much talked about, it gradually dawned on us that we didn't know much that was really useful. That we could do nothing to change the course of the great majority of diseases which we were so busy analyzing, that medicine, for all its facade as a learned profession, was in real life a profoundly ignorant occupation." So where does technology come into that? How can technology potentially offset that feeling, that handicap that so many of us have, that imposter syndrome that we all live with as physicians, just hoping that that case doesn't come in that we haven't reviewed in 10 years or since residency. There's modern innovators in health IT, of course, as well, and health information technology in the way that we carry information. This particular physician, George Gay, is an example of that. He was very well known in cancer therapy. Was the first one to actually create a process for photographing cells in live culture. Was also the first to demonstrate when a cancerous cell became cancerous and actually record it. But what he's more widely known for is a series of cells that he took from a particular patient, now known as Henrietta Lacks, which became the Hela Cells. And there's been a book written about this that some of you may have known about, The Immortal Life of Henrietta Lacks. Hela Cells revolutionized science, revolutionized research. Dr. Gay would carry these cells in a hip pocket to different conferences all over the world, giving them away for free because of how much they meant to the world of research and healthcare. It was a new way of conveying information. Cell lines that didn't exist prior to Henrietta's cells being found out to have an immortal life. And so I think there are some lessons that we should be learning from this and thinking about sort of impacts on ethics and impacts on privacy, because obviously we can look at this from two different angles. One is advancing science, but the other are the unintended consequences of these new technologies. So we talked a little bit about illustration, photography, and biology, and haven't even started yet to talk about digital technology in the way that we've been talking about it here. So I wanted to frame the conversation a little bit with some of that, and then bring up what the hell is this learning health system thing. So my title at Dell Med School is Chief of the Learning Health System. It's a title that I did not create, which is the case for most titles. I think most people apply to a job description because the job description excites them, and then they use most of their career defending the title in some way, and that's kind of how I feel sometimes. Learning health skills, the healthcare system is an idea that was initially brought up by the Institute of Medicine, now the National Academies, and you can sort of read the quote here: "To drive the process of discovery as a natural outgrowth of patient care and to ensure innovation, quality, safety, and value in healthcare." To me, those are a lot of buzzwords, but essentially what it means to me is that in medicine, in general, we suck at following clinical practice guidelines. The American Academy of Neurology might have one guideline for headaches. The American Academy of Family Practice has a completely different set of guidelines for headaches. And there's good reason for that, actually. because of the types of patients that they see, but there's no mechanism for combining those guidelines or for getting patient input into those guidelines in terms of how people did. In fact, I joke about headache and say, I think I'm a pretty good headache, provider, a neurologist. Well, how do you know? Well, they never come back. Patients never come back, right? It's because we don't monitor outcomes in a way. Wouldn't it be great if we had a learning health system, a health system that actually learned from itself? And that's really where this sort of phrase came from. I like borrowing from Voltaire, actually. This is attributed to him. Physicians are individuals who prescribe medicines of which they know little for diseases of which they know less, to persons of whom they know nothing. And this is sort of the perception, I think, that is sort of rampant in society, and it's easy to sort of set physicians up as a target. And I think sometimes we actually do feel like that, if we're honest. And the question is, like, okay, well, what are the systems that we can put in place to sort of counteract and prevent that sort of sensation? I still don't know what a learning health system, though, is, so I get asked these questions all the time. Is it health IT? Is that what you're doing? Is it health policy? Is it health delivery, health research, population health, health education? I get asked these questions a lot. In fact, when I was first hired, I was seen as sort of a threat to the education department. The dean for the college, the education department, had some concerns about who this new young guy was coming in as learning health system role. Well, I know what a nervous system is. I teach about it. Is a nervous system a bunch of brains in a jar? Is it drawings of a brain? Is it the microscopy of brain slides? Is it the radiology and MRIs that we do of brains? And the question is, when we're talking about a system, it's all of these, not one of these. And any innovation that you're engaging in needs to take that into account. It can't just be a health IT innovation. And so as I look at a learning health system, it's all of these, not one of these. And so most of my talk, I'm not going to talk about all of these areas because we wouldn't have time, but I am going to focus a little bit on what I mean by health IT and how I think about health IT. So I'm going to borrow from a model. It's sort of well known, not very well liked across the spectrum, but it's one I'm going to focus on right now. And it's this idea of evolution of data to wisdom. If ultimately what we're doing in health IT is trying to figure out what to do with data, this is one rubric that people have used, this DIKUW model, where you take data and ultimately transitions over into wisdom or evolves into wisdom. Well, how does it do that? If I just give you a bunch of numbers, that's data. 190, 87, 78. Nobody has any idea what that is. As soon as I sprinkle on a little context and say, actually, that's systolic, diastolic blood pressure and heart rate, suddenly you have information. Now, if you start seeing correlations into what that means, you have knowledge. You have microvascular injury resulting from elevated blood pressures, let's say. And then you can start to address things of why things occur, like stroke and heart attack, and gets us to understanding. And then ultimately, wisdom would be the preventative measures necessary to prevent the whole cycle and feedback to the data, right? Our ideal state is that anything we do with data and all the kind of talks that you've seen today sort of migrate us over to the right side. But we all know that that doesn't happen. Otherwise, we wouldn't be having this conversation, I think. And so most of what we do in health IT as CMIOs, CIOs, et cetera, who work in sort of the healthcare IT space is going to be on the left-hand side of that equation for the most part. And so I began asking questions of, what are the kinds of things I can do with data? And I created this rubric when I was inside the military health system, actually, and we used it as a way of gauging the kinds of things that needed funding. And I'll sort of walk you through that. So what are some things that we can do with data if we have data? Well, you can devise new and novel ways to access and make data available. So this would be like quality data, but also sort of some privacy issues associated with that as well. You can talk about data standards and interoperability, and you can work on different programs that deal specifically with standards and interoperability. And I'm using two words there because they're not necessarily interchangeable. Just because something is standard doesn't mean it's interoperable. One of the big issues that we've seen as a consequence of EHRs over the last couple of decades is the migration between terminology sets, starting with ICD-9, going to ICD-10, going to SNOMED. You run into issues around, it might be a standard, but you have backward compatibility issues. You have issues of a one-to-many match, where suddenly your more granular terminology set of ICD-10 matches many different, or one ICD-9 code matches many ICD-10 codes. So which one do you choose? And so we run into these issues where standards don't necessarily mean interoperability. You can talk about new and novel ways to distribute or make data portable. So this would be sort of the mobile sort of revolution that sort of occurred. Different ways to analyze and perform rules against data once you actually do have it. Different ways to visualize or represent that data. An example I give here to my clinical colleagues is I will typically show, even if I draw it in the air, most of you I think who are clinical will probably know, if I drew like a little, I don't know if that's a greater than sign from your perspective or less than sign with a line, and then I do that, it's CBC. And if I were to put numbers in there and show you that for like 2 seconds, you would instantly know, wow, that patient is really sick. You should start IV antibiotics, probably get some fresh frozen plasma in them, and they better be in the ICU. With a split-second decision, whereas what do our EHRs do? We go to that lab section, we spend the first couple of minutes trying to figure out where the WBC column is, and then maybe if we're lucky, it graphs it in some sort of weird way, but for the most part, it's not the kind of system that we have grown up used to in terms of the way that we document. So new ways to visualize and represent data. And then finally, sort of the red-headed stepchild of all of this is the archive and retrieval data. We have this false belief, for example, in radiology that you need to be able to have every single chest x-ray that the person has ever had over their course of their entire life available at a moment's notice, and it's just not true. So what are our archive strategies and our later retrieval strategies? And I had two theories with this, actually. One was that the more, if you identified a project or a application or a solution that was being pitched to me, the more categories that it would fit in, the further along that sort of DIKUW scheme it was. In other words, if I had a project that was only focused on data distribution and portability, if I could add some other things to it, if I could counsel the person or the company or whatever into adding other things, it would get us closer to that wisdom sort of goal. That was a theory. We sort of ran with that, and we happened to have some good endorsement by some congressional funds that came in around 2010, which I won't get into. But initially, the thought was, well, who's at the center of all this? Who's the benefactor of this? And the initial sort of push was, well, of course, it's the physician, right? The physician is trying to get access to this, or the clinical staff, I should say, more importantly. But, we now sort of realize, actually, the person who should have access to that information is the patient, because they're surrounded by multiple team members within the clinical space. And actually, that's not even sufficient, because if we really look at where health happens, health doesn't happen in my 10 by 10 exam room. Health care happens there, but not necessarily health. Health happens where you work, live, play, and pray. It's in the other, for me as a clinician, on average, you come to see me 20 minutes, 5 times a year, 100 minutes a year, I have to influence your health. So most of the health is happening outside of there. So actually, we're not really dealing with the patient so much anymore as dealing with a person in a community. How do we start to access information in new and novel ways outside the traditional healthcare space? How do we get people to think about grocery store receipts are just as important as fingerstick glucose values? If I have an elderly woman come in to see me who has elevated blood glucose settings, that tells me nothing about why. But if I were to say, can you show me your grocery store receipts? Oh, yeah, well, what happened? Why did you buy all these cookies? Well, the grandkids came into town over the weekend, they left, and there were a bunch of cookies left. That helps explain why you're... But we have no mechanism of incorporating these sort of other data sets to help inform care and practice. So are there lessons from the gods that we can sort of think about if we're talking about this innovation sort of role and this sort of broad sort of perspective of what innovation means? And I'm going to walk you through an innovation history in like 3 slides very quickly. The word innovation actually comes from a Greek word, kinotomia, which means to make new cuts, which I just love that from a clinical perspective, actually. It's when you cut a new gallery into a mine. That was sort of where the word came from. And as a concept, innovation has had this very tumultuous history. Today, I think most of us sort of see innovation, even though it's sort of this buzzy word, as something that's positive. Like, oh, that's cool, that's innovative. That would be a positive sort of thing, but it hasn't had that history for most of its history. In fact, one of the first controversies in this sort of history of innovation was this guy, and most people are focused on him. Who is who? Anybody? Henry VIII, okay. So that's Jane Seymour, his 3rd wife. She actually died in childbirth, giving birth to this guy, who is our real innovator in this whole scheme. Edward VI, who in 1548 issued a proclamation at the ripe old age of 9. So that means that he didn't actually issue it, but at any rate, a proclamation against those that doeth innovate. And behind the image, you can actually see the original proclamation, so it wasn't me interpreting something, that's actually what it says. But at the time, what the word innovate actually meant was to go against the teachings and principles of the Church of England. So it had a very different sort of connotation, and if you were known as an innovator, it was actually a very bad thing. In fact, Charles I, about 70 years later, a proclamation for the establishing of the peace and quiet of the Church of England, suppressing dissent, innovation, and controversy. That was followed by this guy, Henry Burton, accusing a bunch of cardinals of being innovators. They actually said, no, we're not innovators, you're the innovator, and they cut off his ears. Years later, the person he accused was beheaded for also being an innovator. So that's the sort of interesting history where innovation has not always had this sort of positive connotation. So where did we get to and how are we there today? So modern definitions of innovation, I'm going to give you sort of 3 examples and then quickly walk through some controversy related to that. So Diffusion of Innovations is a popular book by Everett Rogers talking about how innovation sort of spreads through an industry, and defined as an idea, procedure, or object perceived as new by its adopter. Doesn't mean it's new, it's perceived as new. The OECD has a way of evaluating innovation along product, process, and diffusion metrics. Our friend Larry Page from Google talks about reducing the time between intention and action as being the definition. So let's talk about this improving upon a tool, this sort of creativity, these metrics that people talk about. So if I were to show you this, from the 1830s, this was a new innovation that came out in the 1830s. Anybody want to take a guess at what that is? Non-clinicians? Stethoscope, yeah. So, over a series of the preceding years, multiple feedback, we get to 1961 in the modern Littman stethoscope, which most of us sort of recognize. But when this was first introduced, and we have the sort of digital versions of that now, this was seen as a huge impediment to patient care. It is putting something between me, the doctor, and you, the patient, as a physical barrier impediment. And now I'm paying more attention to this thing rather than to the patient itself, whereas before I just put my ear up against the chest of the patient. Now I have this new technology that is getting in the way of my patient relationship. And these are almost literal the kind of conversations that were happening at the time. And that should resonate with all of us as we talk about the EHR history. What about implications of new tools? Most of us would think if I were to leverage the analogy of medicine being an art and say everybody would agree, hopefully, that this is a piece of art. But I think we would also all agree that all three of these also represent art. So there are implications of tools. So if I were to give you a paintbrush, you might paint the Mona Lisa, but if I give you a chisel, you might carve it. A typewriter, you might do this sort of ASCII rendition of the Mona Lisa, or Photoshop, a photo montage. All of it being art. The challenge is that there are implications when you introduce a new tool. And I want you to extend it and work with me on the analogy of medicine being an art and the EHR being a tool that you introduce. What are some of those implications? I ask simple questions when I talk about this about EHRs. What happens to the art if you choose the wrong tool? How do you know? If I were to give them a toothbrush, could you have still created something that we would have called art in the Mona Lisa? But more importantly, what happens to the artist if you expect the same output? And this is the burnout question. But we also now call joy in practice. There's lots of other sort of phrases for how we talk about burnout in the clinical community. But what happens to the artist if you expect the same output? Nobody would give somebody a chisel and expect them to create the painted Mona Lisa. And yet we're all still expected to create art in the healthcare that we deliver with these new tools. And I don't think this is talked about enough. What happens when things are perceived as new? This is where our hubris gets in, and we all think that we're doing something so innovative when we create that new electronic health record or that new. So here's Sergey Brin from Google wearing some Google glasses. You don't have to go too far back, and you look at Hugo here, who coined the term science fiction with his TV glasses that he was using. So there's countless examples of this in history. For me personally, this showed up a lot in my practice inside the DoD, where we thought we were doing very innovative things. We had this thing called the Healthy Base Initiative, Operation Live Well. Sounds really cool and exciting. It was to try to get everybody interested in being healthy. But you don't have to go too far back and look at Lord Nelson. The great thing in all military service is health, and it is easier for an officer to keep men healthy than for a physician to cure them. And yet we think that this whole healthcare to health movement is new. It's not. The Performance Triad was another initiative under the Surgeon General, a focus on sleep, activity, and nutrition. If we could just get people to focus on those three things, how much that would change and improve health. And there's actually a lot of evidence to suggest that. Sleep, activity, and nutrition. We were very proud of that. Even sounded cool. Performance Triad. We could get our active duty people involved in that. But you go back to Major Letterman and the recollections of the Army of the Potomac, and he said, I would recommend to remedy these evils that food with abundance of fresh vegetables, shelter, rest with moderate amount of exercise be given all the troops. So constantly history is sort of reminding us that we're not the first, including HHS. So at HHS, we had promoting health and preventing disease in 1980. This sparked the Healthy People 2020 initiative, eventually Healthy People 2010 initiative, and the series of cycles that occurred with that. But those darn Canadians beat us to it, actually. So in 1974, a new perspective on health of Canadians. What about outcomes of the community? Now the new buzzword is value-based care. You talk about it. I work with Elizabeth Teisberg, who co-wrote the book with Michael Porter on redefining healthcare. She's actually at Del Med, runs our Value Institute. And a lot of focus now is on focusing on outcomes that matter to patients. So our common metric right now for value in healthcare is the amount I do to you over the cost of doing that to you. And that's how we define value in healthcare under the modern fee-for-service. Value-based healthcare is a change in that narrative. Say, Value is now defined as the outcomes that matter to patients over the cost of delivering those outcomes. So that's, and value-based care is a term that Elizabeth had coined. But you don't have to go too far back in the NHS, and you can look at the Peckham Pioneer Health Center, which ran from 1926 to 1950. They were doing family consultations, measuring patient-reported outcomes over time. It ended in 1950 because the NHS took over. So what does history teach us about innovation? I'll go to Truman. The only thing new in the world is a history you don't know. And as long as we're okay with that, then we can move forward with solutions, potential solutions. So there's a need for efficiency in what we do, and that drove a lot of the early work that I did for DoD. This is an article from New England Journal of Medicine in 2006, right around the time I was trying to hack the military health system. This is an article called Primary Care, Will It Survive? Many of you probably know about this article. It's been estimated that it would take 10 hours per working day to deliver all the recommended care for patients with chronic conditions, plus 7.4 hours per day to provide evidence-based preventative care. That's 18 hours a day just to provide the kind of care that is expected, and yet we only get 20-minute appointments. So reflecting back on how we dealt with this, at the time we had these amazing drop-down lists. This is a screenshot out of the EHR that I was asked to sort of innovate in. Many of you will recognize this. These are medicine terms. At the time, there were over 250,000 of these individual granular terms. And I said, well, if you don't like clicking on these to find the one thing to write your HPI in, what if we make templates for you? So that was supposed to be the next evolution of this to improve our satisfaction as physicians. And then that was later added to with these AIM forms, or alternate input method forms, which are basically just a way to try to put lipstick on a pig and say, let's take all of those templates and put them into some sort of graphical thing that you can more easily click on. I'm not sure if this one is showing it or not, but there are some auto-neg sort of and auto-pause characteristics at this time that were also being employed. We had tremendous fun with this because I could get into the system and pull out individual terms, so I decided to create the best template ever. I'm not sure if you're going to be able to read some of these, but I'll just let you spend a little time. These are actual medicine terms that you could chart in the electronic health records, so I'll just... Recreational activities, competitive sex. I don't know what that is, but, you know, spacecraft accident, so yeah. History of death by legal execution. So we had a lot of fun, like trying to show, like, actually this isn't probably the best way to do this. And it created a note that looked like this, and this was me actually trying to document, trying to be fair to the system, what a headache patient would look like if I were to document it with all of the things that I would typically document in my written note. And the joke for this was it created a note that read more like a ransom note. It was holding us ransom, I think. So the question was, you know, what did it lack? And what we thought was, I came up with this nomenclature of lacking timing, tone, and depth. The EHRs, in most instances, lack the ability to put a term where you want it to put it. So timing is messed up. If you wanted to put that chest pain before the headache, it's not real easy to do that in the automated note that ends up being generated. Tone is which one's more important than another. I think that headache is more important than chest pain because headache to me is subarachnoid hemorrhage. But a cardiologist thinks chest pain is more important because chest pain to them is a heart attack, whereas headache is just a migraine. And so tone becomes important. How do you add tone, or how do you qualify a particular note? And then depth is, imagine writing an in-depth psychiatric intake using just point-and-click terms. So we began to use these sort of terms, and I would speak at a lot of different meetings. I was traveling all over the place, getting a lot of, inside the military in particular, a lot of visibility. I can remember one instance where I was presenting mostly to the Army. I was active duty Navy, and I get a call one day in my clinic, and it's my commanding officer, your cousin, calling me and say, pack your bags, you're going to meet the Surgeon General on Thursday or whatever. And because he heard that you were doing some stuff in the Army, and he wants to know why Navy's not doing it. So it was an interesting way to sort of drive change by playing to the Army-Navy rivalry, actually. But timing, tone, and depth, we began to talk about it. I never spoke with anybody above sort of hospital level, at this time above hospital level sort of commander, and yet it wasn't long before the Assistant Secretary of Defense for Health Affairs policy memo came out that actually had those words. And this was one of my proudest moments, actually, because I had nothing to do with writing this memo. But the judicious addition of free text yields a clinical narrative that has time, tone, and depth, Ward Cassels. And I, at that time, had never met Ward Cassels. I had since got to know him very well. but at the time had no idea that this was even being written or considered. And so seeing that sort of work through the underground sort of way that we were trying to promote the innovations that we were doing was helpful. We began to learn that there was this tension that existed between the art of medicine and the business of medicine that was driving a lot of this, actually, where on the business of medicine side, you had this need to create content and data. We need data, and this sort of productivity, RVU measurements, et cetera. And on the art of medicine side, I just wanted to be efficient. I just want to go home and see my kids. Just write my damn note. Getting back to the earlier note about training, when you train on Microsoft Word, do you learn how to do macros? No. If you later need that, and that's useful, you might learn it on your own. But the EHR approach to training is typically to show you the entire system, not necessarily what you need to know to write your note. The same is true with quality and safety measures and trying to balance that. And so I use medicine terms here as sort of some examples of where we might fall into those quadrants. And the question really for us was, is this an ideal spot? I'm not sure it is. I'm not sure where it is. And so we'll sort of get to that towards the end. So let's talk about insight from innovation history, and I'll end over the next minute. I'm going good right now. I'm sort of pretty proud, actually. I didn't think I'd be this far. All right. So insight from innovation history. Is there a trajectory for innovation? So if I were to walk through sort of some basic history, and the reason I went through all that with Henry VIII is because innovation has seemed to follow this kind of a trajectory, which I sort of label as existential, environmental, and experiential innovation trajectory. In the beginning, innovation was seen as sort of an existential threat. Anything that was being innovated on was an existential threat to the people in power at the time. We get into sort of the Industrial Revolution, and innovation started to really be mastery of our environment. And now as we get into sort of the digital age, it's much more about an experiential innovation that we're seeing, getting us to sort of this digital self. And I've given some examples of what those look like. In healthcare, it's the same thing, except now we're talking about more personal health. And I'll just skip that. It's the same basic concept, but now we're talking about personal health. And everything coming and converging on implantable devices and things that we wear and things that monitor us, and going from not so much this existential innovation or environmental innovation, but things that involve us personally. And that's important because the other thing we need to consider in all of this is the privacy implications of the innovations that we're making. And I'm pulling from a famous Senate debate that occurred between Cicero and Catiline. Catiline was accused of being an innovator and revolutionary in the Roman Senate, was trying to overthrow and execute Cicero, actually. And this is one of the most, this is actually really good for the law people in the room, actually, because it's considered something where a prime example of where the drivers of state control over personal control were sort of first debated, and we have very good accounts of what was said because Cicero wrote it, actually. So there's a little bit of a bias in this, but I really like this quote. What is there? This is from 63 BC. What is there that you did last night? What the night before? Where is it that you were? Who was there that you summoned to meet you? What design was there which was adopted by you, which you think that any one of us is unacquainted? And you think about Mark Zuckerberg and the Facebook sort of challenges now of getting access to personal information. This is sort of the challenges that we're in. In Europe, I sit on a United Nations Task Force for Health Privacy run by Joe Canataci, the Special Rapporteur for Privacy at the United Nations, and we're working on creating a policy statement out of the UN General Assembly on privacy. The big thing that's preoccupying all of my European colleagues is the GDPR. If you don't know about GDPR, it should be a very common topic of conversation in the healthcare space, in my opinion. It's the Global Data Protection Regulation. These are some of the rights to access personal information: right to be forgotten, right to data portability, to be informed, have information corrected, restrict processing, the right to object, and the right to be notified. This has not been consistently, there hasn't been a great measure that I'm aware of at least yet, and maybe you'll counteract this, where this has been applied to healthcare. This is meant to be applied across the board to all innovation, and it's why you have all these cookie checks when you visit a new website now, and you have to click on why am I having to click on all these cookie things? It's because of GDPR, actually.
And that was good?
I think that's good. Yeah, I think it's good. No, I'm not saying the clicking. No, I'm sorry. No, not the 4,000 click thing. I'm saying the renewed emphasis and focus on an individual's right to privacy. Okay. So proportionality and tension in health privacy, this is one of the things I struggle with, and this is my last slide, is there's always seems to be this tension between individual interests versus the interest of other entities. They are legitimate interests, and if we don't start from that perspective, we will never have a meaningful conversation about privacy, because you have a legitimate public health interest. If my neighbor has Ebola, I think I should know about that. I don't care if they don't want me to know about that, right? So there are some legitimate interests The question is trying to articulate those in a way that everybody is satisfied, and this is kind of where we have gotten stuck in this task force, actually. But I just wanted to sort of highlight that as my closing comment. This is Ambroise Paré, a famous surgeon. But anyway.
Reed, do you want to do your super short presentation and then if there's time we'll open it up to questions, or do you want to do
It's actually more a question than, if you want to pull that.
Yeah, and I think now too, just if I'm not mistaken, is that it's more just an open. It's not asking me questions necessarily. This is sort of like, can we have an open conversation as well, or I'm free to do whatever, but yeah, and I'm happy to help sort of negotiate that too.
So, in a number of ways, I think this artifact, if you will, kind of will help us kind of coalesce a number of things, especially the learning health system concept, Stephen. So this is a slide from a public presentation at a conference for people who are interested in what happens in pharmacy prescriptions. So I'm not presenting anything here that's not public. So if you'd go to the next slide, the next slide is simply an enlargement of this lower graph. What this is tracking is something of interest for a number of different reasons. How many of you have read the Fortune article? Okay, please, everybody do. It has its interesting flaws. It's on the website. Fortune Mag, I believe, is the link. But and I don't mean to pick on any individual, but this individual featured himself in the article as a leader, so I think it's fair. So there's a gentleman that I believe is known to Ross who runs a usability lab for MedStar. So this is a research study that was done at MedStar some years ago, and what this tracks is the number of prescriptions written per interval for a drug combination that is known to kill people. So this is a tracking over months' time, concomitant use of two drugs that in this combination, about 1.5% of people die. Those two boxes there are drug safety alerts that were issued by the FDA. This is the information from the e-prescribing system at MedStar. This was presented to senior leadership at MedStar who were in the audience at this conference. And you can see that the increased unabated for a number of years. So the reason I bring this to folks' attention is there are a lot of us who are engaged in these matters in many different ways. Where this is going to be solved is by solving problems in a place where you have standing and where you have a voice. So I have sent this to the authors of the Fortune article, and I will be sending it also to the gentleman featured for the MedStar Usability Lab. Please solve this problem in your home organization first before you tell the rest of us what we should be doing. I'll probably be a little bit more polite about it than that, but I use this as an illustration of one of the things I think that we have also seen today is that the state of EHRs, it is what it is. Whether or not it could have been prevented, modified, improved, whatever, it is what it is today. It's going to be solved now by solving real problems in places where we have control, or by imitating Dr. Willig's institution, which basically established the discipline at the very beginning of their clinical enterprise and has maintained it and built upon it thereafter. So, Steve, can you comment on how in an ideal setting or in a better setting for a learning health system, how this information, which was visible to all clinicians, visible to the risk management officer, visible all the way up to the CEO of MedStar, yet not acted upon.
Yeah, I mean, I'm fine. Maybe I should use
It's kind of the opposite of the learning health system.
That's true. You should have to see the opposite. Yeah. The question is, how do you solve that problem? Yeah, so I mean, I think it's we have the model of delivering healthcare is wrong today, in my opinion, to solve this problem. So we have a sustainability issue that even if you did solve the problem with the great, if it's personality based, it will not sustain, right? So how do you introduce this into sort of a team-based approach to care where other people are also responsible for considering the adverse outcomes of things that you prescribe as a clinician? So one of the advantages at Del Med that we have is we run an entire integrated practice unit model. We have a consensus meeting every Tuesday that talks about every patient coming in that week. We develop a plan and a team, and we go in as a team to see them. The social worker may actually lead the entire conversation with me just showing the MRI. It's a very different model of care. We have an advantage in that the payer that we're partnered with right now is also the reason why the medical school exists, because the taxpayers of Travis County voted on a tax that increased their property tax to build a med school with the explicit intent to improve health in Central Texas. Doesn't happen anywhere else that I'm aware of. So if we need to build a playground to improve health, we build a playground instead of a clinic. So we have some advantages in like creating a system around improving things like this that are not necessarily personality based. And that's my worry about things like this, is that even if you do call that CEO, 5 years, you know how it was in the military health side. So I get this great Surgeon General that's adamant about doing things, and 3 years later has somebody completely new who has to make their own mark for their own, legacy, et cetera, and upends everything that was sort of done before. And the joke about me inside Tatrick was I was the chair of the Interim Solution Committee, because I'd be working on things in the background, and they weren't important until Congress started asking for them. And then it's like, okay, well, if you really want to implement this, then you have to implement a system, not just a single solution to raise yet another red flag every time somebody prescribes this.
Okay, we have a comment from Ross.
So stethoscopes allowed physicians, male in Victorian era, to listen to the hearts of women because they were prohibited from putting their ear onto a naked chest. Yeah. So it was a distancing innovation that worked. The other aspect is that really the invention of risk factors for cardiovascular issues came from local insurance agents in New York who walked their beat and saw their clients weekly to get their 25 cents or something. And they were the ones who saw the relationship between obesity and the like. And it was insurance agents who had motive and data that invented cardiovascular.
Yeah, one of the examples I give in that when I was working for the Surgeon General is to say our chaplain corps spend way more time with our patient population than we do, and yet we have know much more about their health and healthcare status than we ever will. What are we doing to partner with them? And what are we doing with our commissaries, which actually decide, the kinds of things available that our population can eat and consume, et cetera? It's just sort of like changing the model a bit in terms of like how do you begin to think differently about that kind of data? But anyway.
Yeah. Also, it was the same insurance companies that saw relationships between, for instance, diet and what people were eating and weight. The first weight charts were developed by MetLife.
Yeah, although you don't have to go to too many Eastern cultures and sort of see the same kind of thing being done across other cultures as well, where they were starting to recognize the association between proper diet and health outcomes as well. So I think in large part, I do talk about this idea of it's a whole new how, not just what. One of the things I get a lot is when people come to me with a new innovation, they're describing it as if it's completely brand new, and trying to convince them that the what you want to do has been done. You want to improve healthcare access among the under and uninsured. Okay, great. That's been done. How you might do it, the context in which that operates might be different. But if you're okay with the fact that what you're trying to do has been done, and most people in innovation circles are not okay with that. They want it to be the brand new thing that they're pitching. And so I try to sort of stamp my foot about creating a whole new how, not just a what. And getting people to think about what problem they're really trying to solve has also been a major problem.
Any last question? Everybody wants to go home 5 minutes early. Okay. Well, thank you so much to all of our speakers.